Morning, everyone. We're going to start. Thank you. Welcome to everybody. Thanks to everyone for joining us today. So this session that we've organized between TAC and Section 27 is about vaccine literacy. And we've organized it in the tradition of the TAC's treatment literacy program, with a recognition that we as health activists and activists need to know what vaccines are all about. We need to understand the science. We need to know what happens, how they affect our bodies. And we do so remembering one of the giants of TAC's treatment literacy program, Andrew Mosane, who passed recently. So as I say, this session's about learning about vaccines. It's about learning about how they work, how the COVID vaccines work, how they've been developed, how they affect your body, how registration works, what the story with pricing is. And I want to make clear that this is not about the vaccine rollout program. We're not talking about how the vaccines will get for us to ask all of those questions. The content of this session is based on questions that have already been asked. So hopefully some of your initial questions will be answered. But please feel free to ask any questions during the presentations in the chat box. This is both in Zoom and on YouTube. We've got people monitoring both. And we will then collate those questions and ask them of the presenters after their presentations, and then we'll have an opportunity for oral questions as well. So if something comes to you during the presentation, quickly write it down in the chat, but if there are further questions after the presentation, we'll have plenty of time to ask questions, so don't worry about that. So this session has two parts. We start with Dr. Isabella Panunzi, who is a vaccine specialist from MSF. She's based in Brussels. And then we move on to Andy Gray, who's a medicines and medicine policy expert based here in South Africa at KZN. So I'm going to hand over then to Isabella, and you can take us away. Thanks.
Good morning, Sasha. Good morning, everybody. Thanks a lot for inviting me to this session about vaccine COVID-19 literacy. So I'm a medical doctor, infection disease specialist, and I work for MSF Belgium in the vaccination field since 2013. I work together with Catherine Bashi. I saw she joins us today, so this is great. So she can also, I will ask her help to answer some questions if she will remain until the end. And so the two of us, we do work in the vaccination field. We support our project for all vaccination issues. So Sasha already gave to you a bit of the overview, but I would like to start the presentation of today with a poll. And I will ask Sasha to launch the poll, because we are going to launch this at the beginning of the presentation and at the end. So please take your time. It's anonymous, so you should answer the questions, and then we will have the same questions or almost the same at the end of the session. Thanks a lot. I will give you still few moments because I see 56% of participants, of attendees, express their opinion. So you may have some problem in connection or great, I see this, yeah. 70% is already quite good. Okay, I think we can end the pool, so we can start. Yeah. Good. Thanks a lot. Excellent. So I can see a high proportion will accept. We also advise families, members, or friends, and the information was for most of you confusing, which is quite normal because we see everything that is going on in the social media. So it's very good we have the opportunity today to have this chat together. So I will start to share my screen. Just tell me if you can see it. Yes. Yeah?
Yes, your screen is visible. Your screen is visible.
Hello?
Yes, the screen is visible.
We can see. Thanks, Isabella.
Great. Okay, excellent. So Sasha already gave an introduction. This is the outline. So I receive a lot of questions. Thanks a lot to each one of you and to Sasha to share them, because it was very, very useful to develop the presentation. And so what I want to clarify today is that there is a lot of information, scientific information available. This changes very quickly. So almost yesterday I got new evidence that I added to the presentation. So it's possible that tomorrow, the day after tomorrow, something else will come. So I really try to put information that cannot be contradicted in few days, but just to tell you that information, evidence is coming out almost every day about the vaccines, or as well the access to these vaccines. But then, that said, so the idea is to discuss a bit about the role of vaccination, because it's the most important, the base to then understand COVID-19 vaccines. Then to give an overview of COVID-19 candidates vaccine. I'm not going to talk about all of them, but only those that until today are likely to reach South Africa. So those that you may be receiving in the coming months. Then the objective of COVID-19 vaccination program is, which is really important to understand then how this will happen, then the groups, and then also a little bit about access, because then Andrew will talk to you, will share with you what is the process in South Africa. So I took this from the health program website, and then this is one of the information that is provided. Is absolutely true. The vaccine saves 5 lives every minute. So the picture I put below is the smallpox. Indeed, so it was a deadly disease before the vaccine became available many, many years ago, hundreds of years ago. And we can say that even if the people was not killed, they will live with scars of the disease. So still the quality of life was affected, not only the life. And so this is just to show you a bit the some other vaccines, so diphtheria, some other diseases, and the vaccine that they exist, which have really reduced dramatically the prevalence of the disease, so the number of cases we see, the deaths, but also the number of cases of diphtheria, pertussis, and measles. So measles is one of the main reasons of death still today in African countries, and everywhere the coverage decreases. So this is very important as well to say. So success of vaccines is linked to the coverage, which means the number of people that are vaccinated. So it's something we need to monitor all the time because it's very, very important. So vaccine exists, they are effective, we know, because we saw diseases disappearing, we saw number of cases dropping, but still we see that where people are hesitant toward vaccination, we see these old diseases coming back. And we even say re-emerging, as has been the case of diphtheria, for example. We, as MSF, have been intervening in outbreak of diphtheria when, for example, me, as a medical doctor, haven't seen any case during my studies. So I did see cases because we do intervene to outbreaks of a disease which should have disappeared by now. So what I want to tell you, because you always hear about success of vaccine, they are very effective, the most effective public health intervention. But working in vaccination, I learned myself that there are also some threats associated with vaccination. One of them is that the vaccine are victims of their success. What I was telling you is because if a vaccine is effective, the disease disappears. So the people is not afraid anymore, doesn't see the disease, so they believe that the disease is not an issue, is not a threat anymore. So for this, the confidence, also the need of a vaccine decreases. Very, very important is as well that vaccines are provided to healthy individuals. This may seem to you something obvious, but it's not, because all the medical products, so medicines are provided for people that is sick or symptoms. And we all know when we have a headache, we just want to get rid of it. And we take a paracetamol or any other drug, not knowing that this drug has side effects, but still we want to get rid of the headache. When we are healthy and we are perfectly fine, even a small side effects given by a vaccine is going to be very disappointing. So this is also a reason why the expectations are so high for vaccines. A very, very important key for all of us is the false sense of security that is wrongly associated with vaccination. Why? Because I get a vaccine, I feel I'm protected, so I start reducing the other barriers or the other measures. This is a key message we always give in our campaigns or any intervention we do about vaccination. Health promotion is also key for vaccination for this reason, because we need to explain clearly what it means to get vaccinated, what is the risk associated still, even if somebody is vaccinated. So I think this is a very important message we all need to have very clear when we discuss about vaccine and vaccination. So before going about vaccines, I think it's very important to remind all of you how the immune system works. So what I did, I just took a video on YouTube, which is very, very nice, very, very clear, a few minutes, but it was very difficult to share the video with you today during the Zoom. We have tried in the past, it doesn't work. I just put the link of the video in the presentation. You will get the presentation after, but so for you to see it again, if something is still unclear. So how our immune system works. Then we know there is a virus, a bacteria, but let's talk about a virus. In this case, it's the coronavirus, which is going to enter our body. It's going to attach to our cells. Then is going to introduce in the cells the message about what the virus wants our cell to produce. Then the cell is going to start producing more viruses that they go around in the body, and they are going to cause the symptoms. So fever is one of them, or any other symptom you can imagine about SARS-CoV-2. Then what will happen, our immune system, which is very effective, is going to react, is going to develop antibodies to stop the viruses. But this will take some time. So the immune system is amazing in killing an intruder in our organism, but is slow to attack because it needs time. This is just the reason. If for some people, the time may be longer. For example, old people, we call indeed immunosenescence, which is, we can say the immune system, we get a bit tired, so it will take even longer to react. Or people with some a weak immune system for several reasons. So what we do with vaccination? With vaccines, we actually train our immune system. We train them to be able to react very quickly, to be then on shape, to be able then to act when this is needed. It's just like to show a picture to the immune system to tell, kill it as soon as you see it. And then this will allow the immune system to be ready, to have a memory, and then every time we are going to see, to encounter the same virus, we are not going to develop symptoms anymore. We are not going to get sick anymore. And so this is actually how is the theory behind vaccines. So what is immunization indeed? It's a method which is used to prevent people to get sick from a vaccine preventable disease. Not all diseases, unfortunately, are preventable, but more and more are today. For example, Ebola, until a few years ago, even less, was not vaccine preventable. Today it is, thanks to the science and to the developments. So what is a vaccine? A vaccine is prepared by a killed virus. We will see this later, the different platform used, and then is used to induce or increase the immunity against this specific pathogen, a virus, a bacteria. So why immunization is different from vaccination? So you get a vaccine, but then immunization, it means that your immune system is going to react to this vaccination. So which means you get an injection or oral, or there are different ways of administering vaccine today, and then your immune system is going to react. And in a few weeks, 10 days or more, also depending on the number of doses, you are going to be able to react to this pathogen. Now, protection, the role of vaccination is very important for several reasons, I will tell you. But what is very important is that, so you get vaccinated, if you get immune, if you react to this vaccine, you get protected, you get immune. But no vaccine is effective 100%. So it's still possible that for some specific reason, because your immune system is weak, because also your age, etc., you are not immune even if you get vaccinated. So this is very important to know for what I was telling you before about the false sense of security, but still vaccination is useful to protect individuals against the disease and the consequences, as I told you, for smallpox, not only killing people, but also the scar that the people had to live with. Then reduce the severity of the disease. So even if you get the disease, you don't die for this disease. We see this, for example, with measles or many other diseases, when then you get a life form of the disease. Then very, very important, reduce the probability of the virus circulating. I'm talking about virus, but I mean all pathogens for which a vaccine is available. And then a person who is susceptible because has not been vaccinated, didn't have the disease, to get the infection. So this is what we call herd immunity. So to explain to you a bit what herd immunity is, because I really like the way South African health department is presenting this in the iconography they use. Why? Because in the community you have different type of people in terms of immunity, I mean. So you have those that are not immunized but are healthy. Then you have those that are not immunized, that are sick, so of a disease, it can then transmit the disease to others. Then you have those that are immune, those that are in yellow in the picture. Then you see in the community, the number of people immunized may change. And some of the population get immunized, which means that contagious disease can still spread, but only through the people that is not immunized. So higher is the proportion of the people that is immunized, protected, then it means less likely is the probability of a virus to circulate and then to affect the person that is not immune. So this is very important. Why? Because herd immunity is not a concept linked to the person, but is a concept linked to the community. So a person is protected as far as lives in a community where vaccination coverage is high. So if this person is going to move in another community, the protection does not last. So the person became again susceptible. This is something we see all the time with refugees or displaced populations in our work as MSF. So this is about herd immunity specifically to SARS-CoV-2. So herd immunity is a proportion. Is a proportion, it means is the proportion of the population which needs to be vaccinated in order for the susceptible to be protected in this community. So this is a calculation done with a formula, epidemiological formula, and the variables used to calculate this value are specific to each pathogen. So one of these variables is the contagiousness. So is the probability of one pathogen to affect the other one or to be transmitted. So this will depend on the way of transmission and several factors. Anyway, each pathogen has a specific, let's say, value for this, which is the probability of one person with the disease to spread to the disease to others, the infection to spread the infection to others. So this is the number you see on the bottom, which is the basic reproductive number, which is a value specific to each pathogen. And for SARS-CoV-2 is around 2, which means one person with SARS-CoV-2 is able to infect other 2 people on average. You see measles is very high, is the highest we can say. So this means that one person with measles is able to infect around 15 other susceptible individuals. So why this is important? Because this number is used in the formula to calculate the proportion of people that needs to be immune in the population to protect those that, because of a weak immune system, don't have access to the vaccine, cannot be vaccinated. So is the number we need to have in order to have this collective effect of vaccination. And so this is a very important concept, also because you saw in South Africa, they aim to reach 67% of coverage, is linked indeed to this 60% you see on the left, because for SARS-CoV-2, the calculation has showed that coverage must be at least above 60% in order to use the herd immunity, to have the herd immunity in the population. But 2 points. This really depends on the impact of your vaccine on transmission. This is something I will tell you later. It depends on the how effective is your virus in transmitting. So this also depends on variants. I think now you became very used to the word variants. I will talk to you about it just in a few seconds. So this is the concept of herd immunity, is very important, and I hope it's clear. If not, please ask questions. I will try to explain this again. So now about vaccines. So we saw the vaccines, why are so important. We saw the role of vaccination. So now I wanted to show you how vaccines are developed. So this picture taken from Nature, which is a very nice article about that, then shows how long is the process to develop a vaccine. Usually it's 15 years. So you see that there are the preclinical phases where we do test vaccines in animals, because we need to test the safety. So we cannot start right away with humans. Then when we have the data, this takes already years, we can go to what we call clinical phase. So the clinical phase, it means that humans are involved. Then you have phase 1, phase 2, and phase 3. Now, you all know these terms because they've become very common in the media. And then the phase 1 and phase 2 are done in a small number of people. Phase 1 is to see the safety. Phase 2 is what is called exploratory studies, because the scientists try to identify the very good schedule, which means how many doses, what is the right interval for this population, and then they start the phase 3 when they have completed the others. And the phase 3 is actually to really see in a larger group of people, so thousands of people, to see actually really the safety in a larger number, and also the effectiveness in this, in the efficiency in this large number. Then when everything is done, you have a file which is presented to regulatory body, and usually it takes also time to this expert to evaluate all the results. You have also external body, usually is the expert group in immunization of the WHO, that they give their opinion and also their advice about the schedule. So how to implement a vaccine in a country. So what is the best interval, what is the best schedule? And then the vaccines start to get produced, which also requires some time, depending on the vaccine. So this used to take 15 years on average. Now, I will show you what has been the process for SARS-CoV candidates. And I will tell you why has been shorter. So you see that for SARS-CoV-2, we are able to have a candidate vaccine, so vaccines on the market already after 10 months, one year and a half, depending on the number and on where. So this has been possible. Why? Because you know about SARS and MERS, that they were also the epidemic before. And so there were a lot of preclinical studies done. They were about to produce a vaccine at that time, but because then the epidemic stopped, then they were not studied done anymore or investment done anymore. But then this knowledge remained there available. So it was possible to get it back when then SARS-CoV-2 became a threat. Then this allows them to start also the testing for some candidates, not all, because we still have candidates in the preclinical phase. I will tell you later. But then this allows to do then different phases overlapping. So they didn't wait for one on the other to stop, to finish, but then they did the 3 almost at the same time, apart the phase 3 for which they needed to complete the other to start. Then regulatory body were also involved in phases. It means they didn't get the full file at the end, but then there was often a communication between the company and the regulatory body. There was a lot of investment of government, as you know well, for example, US and others. And then this speed for sure a lot up the process. Another point was that when we are in a pandemic, we have a lot of number of cases to test a vaccine. What we do usually a study for a vaccine for which a disease exists but is rare, we need to wait for a case to test the vaccine, which means this may take some time. During a pandemic, you have so many cases that it's very easy to be able to see the effect of a vaccine on these cases. So the fact of testing a vaccine during a pandemic was the main reason why the process could be so quick. But for sure, the speed of the process has not compromised at all the safety and efficiency let's say, indicators. So this has been for sure followed as for any other vaccine, for those vaccines that were developed in 50 years time with a delay of 15 years. But the point is that just because the condition, the context, just because this science, the progress the science did before, then was possible to have vaccine ready in a short time. And the same point is as well about the production. You know that vaccines started to be produced even before the phase 3 was finished, obviously in a small number. But then this means, and then at the same time when a trial, phase 3 finished, the regulatory body can provide the opinion and the final decision, the vaccine can be put in the market. So you don't need a delay, because vaccines, depending on the technology used, may require some time to be produced. Even so, when you have the consent of the regulatory body, you may have a delay of months, as we anyway are experiencing now. So this is the same as before, but I like it a lot. Why? Because it shows the phase 4. So phase 4 is something we don't usually hear about in the media, but it's something very crucial. Why? Because for any drug, any product, there is a post-marketing monitoring, which is absolutely needed to identify rare side effects. Because even if in the trial you monitor carefully, you identify if a headache was really associated with this vaccine, then you have a small number of people, even if in the trial of COVID vaccine, thousands of people were included, so even more than what was usually done, but still you will have no million of people. So you will have the opportunity in phase 4 to identify rare side effects. And then this is the reason why for COVID-19 vaccine, then there is a lot of attention in phase 4. The attention to really monitor and be able to detect any side effect may be related to vaccination. Then this is to show you indeed about COVID-19 vaccine expectations. There are the same expectation we have for any vaccine. So an infection disease is very special. Why? Because you can get the infection, but still you may not get the disease. So this is for the example of HIV. HIV, you get HIV virus, you get infected, but you may not get a SIDA, so the disease, years after. So this is specific to all infection diseases. So a vaccine, we want from a vaccine to be able to avoid infection. We want also from a vaccine to be able to avoid when an infection already occurred to be sick, to become sick, even to die from the disease. We also want from a vaccine that the person that is infected is not going to transmit the infection to any other. We also want from a vaccine that the protection lasts for life. So we want a long-lasting protection. And lifelong, what we say, and we know for some vaccine we need several doses to reach this, for others we don't. But for sure we want to just get one shot or few and not to have to think about it 1 year after, 2 or 3. So this is what we do expect from vaccines. But what we do have today from the candidates, from the results we know, so from the data we have. So we know indeed that the vaccine, the candidates, the most advanced, I will tell you after about that. We know that they prevent reduced infection. We know that they for sure prevent a person who is infected from being severely ill, from dying of the disease. So we do avoid that this person is going to go to the hospital, is going to go to an ICU, is going to overwhelm the health system as well. But we don't know, I mean, which doesn't mean this is not possible, but we don't know from the data we have because the numbers are too small, but then all the scientists are working on this question. We don't know if the vaccine is effective in preventing infection. So when you get vaccinated, we don't know if you are able to avoid that if infected, you will transmit this to others. And what we don't know for sure is how long the immunity will last. We don't know just because this is obvious. The first people that they got this candidate vaccine were vaccinated in June, July. So we have only today 6 months of time to see if we take a blood sample from this person to see if the immune system is still reacting, is still there, if the memory cell I told you about before are still there. So we will need time. These trials are going on for 2 years at least to see if then after 2 years the vaccine remains still effective, which means the immune system still has a memory, is able to protect us from the intruder. So this is what we know today about this vaccine. So you saw the expectation, we saw what we have, which is not optimal, but is a lot. And I'm sure in the coming months will change because more evidence will come. And also what we know, okay, we get protected from a severe disease. This is something we know very well. Somebody sick with symptoms is more infectious than somebody who doesn't have symptoms. So of course, if we avoid somebody to get sick, to cough, for example, etc., is very likely that we are going to impact the transmission anyway, because this person is not going to be a spreader or to spread the disease if if she had symptoms. So this is a very nice picture showing a bit about what are the classical and new platform, I mean, the basis used to develop vaccines. And in the middle, you see the well-known SARS-CoV-2. We know this, we know the spikes protein, that there are those that are targeted by most of the vaccine on development, even if it's important for you to know that not all vaccines candidates target the spike. So some targets also other components, which is a good news, because if the spike protein is going to mutate, etc., some vaccines may still, other candidates may still remain effective. So on the left, you see what we call classical platform. Why classical? Because vaccines are being developed. We have vaccine for years now that we use, for which we have a lot of knowledge and understanding from this platform. On the right, you see the next generation platform, so the new. When I say new, doesn't mean that this is an unknown. I mean new because it means that there was not vaccine available until today, but there is a lot of knowledge about this platform. So just to tell you, mRNA vaccines are developed on a platform that was used to study treatment of cancer before, and also chronic diseases. So there is more than 50 years of studies and knowledge about this platform. So it doesn't mean that they are new to scientists. It means that this is the first time we have a vaccine available with this platform. So I don't want to really go more in details about the platform. This was really to show you a bit what exists before, what exists now. And you can ask me questions if you want about a specific platform, but it's just to tell you that each platform, then it means the way the immune system is induced is different. The likelihood of have long protection or not, because the knowledge we have about existing vaccines. For example, you see polio vaccine is a whole inactivated virus. So inactivated virus, polio virus is used to induce immunity. So to, let's say, give this wanted picture to the immune system to be able to recognize poliovirus when we get in contact with that, and so on for all the others. So this, I took it from yesterday from the London School. They have a very nice tracker system for all the vaccines available. So you see in the picture, you see on the left the platform. That is what was before with the form of the virus. And then you see the different phases, preclinical, phase 1, 2, 3, and then also you see those that are used today. So you see where we have almost 300 vaccines in preclinical. They change all the time, so I won't be surprised if in a few days the numbers have changed. Then we have 49 in clinical and 20 are in phase 3, which is very good news. And we know that there are several vaccines more every day registered by stringent regulatory authorities, which are recognized regulatory bodies that have given their emergency approval, conditional approval for these vaccines. So I don't know, because when I'm saying about conditional emergency approval is very important, because most of the authorities have approved the vaccine and emergency approval because of the unusual circumstances, which is the pandemic, because there is not other drug available or treatment. But indeed, all these authorities are still looking for data information. So there is a straight communication between them and the companies in order to answer some of the unanswered questions we still have today, like the impact on transmission, or also the length of the immunity about these candidates. So this is a table with just what are the most advanced vaccines, candidates vaccines. Some of them are already in use in different countries. So I put them the vaccines for which we have more information or for which we had to get information because they are used in the context where MSF intervenes, so we need to have information about them, but also because some of them are those that are going to be available in South Africa. So there is the Pfizer vaccine and the AstraZeneca. They are the two vaccines together with the Johnson & Johnson that for which there is a deal. So the doses are going to be provided to South Africa, hopefully soon, depending on the different deal and the different mechanism. And Johnson & Johnson, I haven't put because we don't have any information. There are been publication about the phase 2 trial, but the phase 3 are going to be published very soon. Results are expected in days. So soon I will have as well information about Johnson & Johnson. Johnson & Johnson is a vaccine for which there is a lot of hope because it's one dose vaccine. So they also implemented the study for one dose, but the information we have until today about the one dose is not, let's say, extremely promising because it seems still two doses is more effective, but information will come available soon. So to talk about the vaccine for which we have information today, I will concentrate on the Pfizer and on the AstraZeneca vaccine because are those you will see in South Africa soon. So the Pfizer vaccine is an mRNA vaccine, as you know now, is 2 doses. They need to be given 20 days apart. So the results have been published. There is the evidence on 95% efficacy, but the immunity starts at least 7 days after the second dose. So this is very also important. So you don't get vaccinated immune straight away, but you need to give time to the immune system to react, to build this memory I showed you before. A big challenge of this vaccine is the cold chain requirement because it must be kept below 70 Celsius degree. It can be kept out of in what we called hyper cold chain for 5 days. This is what is used, for example, in Belgium now to distribute the vaccine to the health facilities. Then the price is quite expensive. It's $15–20 per dose. A very important point, this is not public. So the negotiation between countries, the companies are not public. I mean, the final price that the country is going to pay usually are not made public. Sometimes are. There are exceptions, but this is not the rule. And then so far, Pfizer have been approved by FDA and also WHO give indeed the expert group of immunization release recommendations about Pfizer vaccine and has been also approved by the European Medical Agency and then in other countries as well. So this I got it from the product insert, which is what you find with the drugs every time you buy them. And then is about side effects, the most common side effects of the Pfizer vaccine. So you see in the table is very clear. I choose to put this because you saw how side effects are classified, other content, how their likelihood. So which means very common when they happen to more than one person over 10, when they are rare, when they happen in more than one person on 1,000. And so this is indeed very clear. You see that the most common side effects is headache, arthralgia, myalgia, which is very common, also very similar to the SARS-CoV-2 symptoms, so flu symptoms, and also injection site, which is very common, fatigue and fever, and also swelling to the injection site. And then there are the more rare side effects that is also possible. Then this is for the trials, and this is also compared to Moderna, which is also an mRNA vaccine. The two vaccines have very similar side effects, and as you can see from the tables, they are more common in young people, and they are more common in the second dose. These side effects, which still remain frequent. And so you see the list I give you before on the table, but this was just to show you that usually younger people get also more pain, let's say in the injection site or headache, but not severe side effects. Then the AstraZeneca vaccine is using they use an adenovirus as a platform. Is 2 doses, 20 days apart. The preliminary results show also high efficacy with the 2 doses. Still, you need to wait 1 week at least for your immune system to react. And the cold chain in this case is very, let's say, doable, which is 6 months for between 2 and 8 degrees, which is common to all vaccines. So all vaccines, apart some exceptions, they need to be kept in a strict cold chain conditions. And the production capacity is very high, is the one with the highest production capacity, also because they transferred the technology to Serum Institute of India. Indeed, South Africa will buy the vaccine from India, from the Serum Institute of India, and the price is lower of the indeed mRNA vaccines is about $5 per dose, and has been already authorized and is in use in some countries. And I know from a review that the price that South Africa paid is about $7 per dose. This, as I told you, is because of the negotiation done between the country and the company. So the side effects of the AstraZeneca vaccine is almost the same, so it's quite similar actually. And as you see, is also the classification in very common, common, and uncommon. And then the ranges are different. So this is very important because it really depends on the results on the trials. And then you say that the very common are side effects which are very mild. And then also feeling unwell, feeling tired, so fatigue, headache, feeling sick. And then there are indeed more uncommon side effects, which may be more severe. But all to say that very often, if not to say the majority of the cases, these side effects, they last only for 48, 72 hours. They don't require any treatment, and they are self-limiting for what we have seen today, what we have seen from the trials. So then to go to the really practical aspect of objective of COVID-19 vaccination program. So usually when we do a vaccination campaign, we do very often in MSF, what we want is to reach a very large number of the population for this famous concept of herd immunity, so to be able to protect also those not vaccinated, and with a vaccine which is very effective, high effective in preventing the infection. Then unfortunately, what we know today is there is no evidence on transmission, and also we don't have vaccine to cover this large number of the population. So for this, we already know that the vaccination cannot be today the solution to the pandemic, in the sense that it's not going to stop the pandemic straight away. In the initial phase of the program, indeed, the objective is to prevent morbidity and mortality in the groups most at risk, and so is to avoid the burden on the health system, which we know has been a big issue linked to the pandemic, because we know that many people are dying because no COVID-related health issues. So all these deaths may be also avoided by vaccination, by COVID-19 vaccination, if the health system is, let's say, not overwhelmed. And what is really key, linked to the false sense of security of vaccination, is that other preventive measures need to remain in place all the time, because there is no vaccine which is 100% effective. But in this phase of the vaccination program, for sure, because indeed there is not everybody is going to get the vaccine, and there is no information about prevention of transmission. So we still need to live with this measure for some time. So this I wanted to show you because it's linked the role of vaccination, even when many people got already SARS-CoV-2, because we know you have for sure friends or yourself, you got already SARS-CoV-2. And so there is this idea of, let's say, protection from previous infection. And there was a very nice study done in South Africa where there was a seroprevalence study, which means that they got the blood of people and they look for antibodies, and then the result was very high, in the sense that they saw that there was a very high proportion of people with antibody, but this was very short after the first wave, and also was not taking into account indeed the variants. But what we know from an article published recently is that indeed the protection for previous infection is not absolute, it does not last long. So even people with previous infections, previous disease, who was sick before, is not protected. So it still should still be targeted by vaccination, and vaccination is still a huge add value for these people. Also because we see, this is from South Africa, then the first wave did not avoid the second wave to happen. So this is quite obvious that immunity is not very high in the population, and then previous disease does not protect from a second one if the delay is long enough. Also because we see that the second wave is even higher, as many experts were expecting, than the first one as anywhere else. So not just South Africa, unfortunately. So this is just because I told you about groups. This is indeed the choice of South Africa. I got it from the website. So this was the choice about the groups that they decide to prioritize with the concept that then the vaccine cannot be for everybody, and we want to avoid the burden. So these groups that are more at risk, and health workers, because even if they are usually younger, young is a young population, but they are key to avoid the burden and to allow the system to continue working. And also because if, as we think, there is any way an effect on transmission, it's very important to include them in the vaccination program at the beginning. And so now just a few words about the risk. Who are those at risk of SARS? So who are those targeted by COVID-19 vaccination? This is a table that shows how the risk increases very, I would say, highly with the age for hospitalization and for deaths. So you see that in old people, in somebody above 75 years of age, is 85 times more likely to be hospitalized and to die compared to somebody of less than 30 years old. So age is for sure a criteria. Then also other comorbidities. This is a list from CDC. Chronic kidney disease, lung diseases, so tuberculosis for sure is as well then a chronic lung disease. For sure, indeed, also SARS-CoV-2 has been shown to be very aggressive in people with previous TB. Chronic cardiovascular diseases, immunocompromise, so also poorly controlled HIV or AIDS. I saw there was this question in the panel, and immunocompromised for any other reason. Also obesity, because this has been one of the factors associated with high mortality. This is now well known. Sickle cell disease, diabetes, and smoking, as well as obesity has been associated with high mortality. Pregnancy, I don't put it in comorbidities because pregnancy is not a disease, but still pregnant people have been shown to have high risk of severe disease, and then also bad outcome for them and the fetus. And then people with HIV should be considered a high risk group for COVID-19 management. So they are indeed a target for vaccination as soon as data became available. And this I will show you straight away. So now contraindication, versus lack of data, because there is always a confusion. What is a contraindication and what is indeed lack of available data? So the only contraindication in general to vaccination and also to COVID-19 vaccine is a history of severe allergic reaction to any component of the vaccine. So I look in the leaflet of the vaccine we have today, and there is the same indeed information everywhere as is for any other vaccine. Then Other groups are included in the contraindication, but just because sometimes there are precautions and sometimes because there is lack of evidence. So precautions, a history of any immediate allergic reaction to any other vaccine or injectable, representing precautions, but is not a contraindication. So still the doctor may decide according to the risk group to which the person belongs to administer COVID-19 vaccine. Also, treatment with anticoagulants is precautions, but is not a contraindication. Then food, contact, or seasonal allergy, which are very common depending also on the settings, are not even a precaution to COVID-19 vaccination. So they do not at all a risk or need to consider case by case. Then lack of data. Pregnancy, lactating women, children below 16, 18 years, according to the vaccine. Why? Because these groups are not in the trials, so we don't have data, and for sure we cannot provide any drugs or vaccine to somebody for which we don't have data about. Immunocompromise, I told you HIV positive people are more at risk of COVID, but there are no data about how the vaccine is effective and safe in this group. For those vaccines that they are not live vaccine, specialists, experts think that there is not issue because there is not a real contraindication, but we don't know, there are no data. So this needs to be a decision taken by the medical doctor who is knowing the case, and for sure by the person, because still this remains a personal decision. Then very important to say also, no contradiction to vaccination is a previous infection with COVID-19. As I told you, it's not a contraindication, or even we show that there is not immunity lasting, but WHO today recommends at least to avoid an acute phase of the disease. For any acute condition, we do prefer to delay vaccination if you have high fever or heal. But for WHO, for example, they do indeed say that a person with previous COVID should be vaccinated 6 months after at least, but only because there is a lack of vaccine for everybody today. So if it's possible, they should not be in the first group, but no country until today has been doing a screening. So also a person with previous COVID-19 infection have been vaccinated because there is not issue. And also no contraindication is a stable comorbidity like diabetes, cancer, hepatitis B, also well managed and stable HIV. So there is not contraindication at all. The only, again, for HIV, as there was a question, when there is a stable HIV, so not well controlled, then it needs to be a very careful, thoughtful decision taken by the doctor and the person. Then now variants. Variants, because are very famous today, and because there is little evidence available. And what is a variant? So viruses, they mutate all the time. It's like the nature, no way. They do mutate all the time, but when a number of mutations became relevant, important, then this is called a variant. And so there are variants that are more effective in transmission. So they allow, let's say, survival of the virus, and then which means these are good variants, which are going to survive on the long run. And you know very well that now there is this South African variant that has been detected in several countries, and we know the evidence today is the transmissibility appears to be higher, this variant. So if you recall the reproductive number I show you, so the probability of one person with SARS-CoV to infect other 2 persons, we do believe that for these variants, like for others, the UK one, for example, there is a higher number of people can be infected just because it's more transmissible as a better partner for transmissibility. So this is known. About the effect on vaccination, so yesterday there was a press release for Moderna, which is one of the 2 companies with an mRNA vaccine. as Pfizer, and they tested actually apparently the serum of the vaccinated people against this variant, and apparently there is still neutralizing value of this antibody, which means it seems then the Moderna vaccine is still effective against these variants. And experts, before the press release was available, already said that it was very likely not to have an impact. So this is what already we knew, but this press release about the Moderna vaccine gives some more information, and more information will become available for sure in the coming days. I believe Pfizer will do exactly the same as Moderna. So now, almost at the end, I know it's been a long presentation with a lot of information. I'm sorry, but I used your question to be sure I could cover all the issues, but we can go back anytime with your questions after. So the distribution mechanism. So the first way the countries have to get access to this vaccine is an advance purchase agreement. What means is an agreement, a deal between the country and the company. This, of course, is very convenient for the company and somehow also for the country because they want to assure the doses for the population. But this is very unfortunate for the community, for the world, I would say, also because some countries with this deal have secured 50% of the doses that are going to be available in 2 years' time to cover 3-4 times their population. So this is very important to know. Then the COVAX is a facility that has been created by several bodies, OMS, WHO, sorry, this is in French, WHO is part of this facility. Is a facility created to allow equity in the distribution system of COVID-19 vaccines candidate. So to be sure that any country, any person get access to this vaccine, regardless where do they live, how high is the income of their country. So they have signed for 92, more than 92 countries have signed, and more sign every day. Also, US said that they want to become part of the COVAX facility. So more vaccine also apply are part of it. Also, the Russian vaccine applied to be part of the COVAX facility, the Chinese one as well recently. So they have a gap, a financing gap already for 7.5 million. And they will get the vaccine only when the purchase agreement have been already, let's say, secured. And with the doses that they have secured, we know that they will be able to cover only 20% of the population in low and middle income countries, so won't be at all enough to reach what we saw was the herd immunity. Then there is also the African Vaccination Acquisition Task Force team, AVAT, and then is indeed a coalition of several African countries, and they are been working as a group to try to have deals with the companies in order to ensure 270 million doses for African countries, as some of them available shortly, which is what is needed. And this deal has been made with 3 companies: Pfizer, AstraZeneca, Johnson & Johnson. This is the reason why I mentioned to you the 2 vaccines for which we have information. Johnson & Johnson we don't have at all at the moment about the phase 3, so I could not share with you. So this is the existing distribution mechanism, just for you to have an idea. NGOs like MSF don't have access to the vaccine today. So as health workers, as group at risk, or anyway as health provider, so we cannot ensure vaccines for our beneficiaries in the coming future, in the near future, because it's not clear at all how we're going to be able to access, because we cannot buy the vaccines, we cannot do an advance purchase agreement with the company, we don't want to. And so we do rely indeed in try to find access for all the NGOs, humanitarian actors, and not only for MSF. We have been working on that since June, with the Access campaign, which is the part of MSF who has been working access for drugs. You know this, I think, very well for the HIV drugs, and has been trying since the beginning to really make this vaccine accessible to everybody and also to humanitarian actors. So this is just to show you, indeed, then the rich country will get access to COVID-19 vaccines earlier, we know. For late, I mean very late in the pandemic, because you can see in red the projection, they talk about April 22, so which means already more than 1 year from now. And this is indeed the snapshot of the bilateral multilateral agreement. I put it because there is South Africa there. You can see on the right. You can see then the bilateral agreement that South Africa did as well, individually with the two companies to ensure indeed the doses for South Africans and for the citizen, and then the deals has been with AstraZeneca and Johnson & Johnson. I think very recently this has happened. And then you can see all the other countries there. These get updated weekly. Then now for me, a very important point, if not say one of the most important. So I talked about vaccines, I talked about the added value of vaccination, the threats of vaccination, about how vaccines are developed, COVID-19 vaccines. But for vaccination, I mean, there is nothing we can do if the people, they don't trust the vaccine, if they don't accept to get vaccinated. So you see there have been a lot of surveys done before, and this is just one of them. And I like it because South Africa is in there. They ask actually the question to the people, if the vaccine is available, are you going to get vaccinated immediately, within 3 months, 1 year? So you see in South Africa, 21% answered this question. And this was already done in October. And within 3 months, the proportion increased, and more in 1 year. I think also because they want to see how it goes before getting vaccinated. Still, 21% is very low, is very worrying. And this, sorry, it's not very good, but it comes from a presentation from DRC where they show actually the results indeed of the trend of vaccination acceptance in the world and in Africa. So South Africa is also there. So they did a survey where they asked if they were going to get vaccinated. The survey was done in August, and the answer from South Africa was 68%. They ran again the survey in October, 64% of people accepted, which means there was a drop, so not an increase. So the situation is not getting any better with all this information going on the social media and the infodemic, as WHO called all this misinformation, which is for me more dangerous than COVID-19, the SARS-CoV-2 itself. Good. I have done with the presentation, and I think now is the time for your questions or to clarify things that were not clear because I ran too much or I used terms that were not very clear to you. Thanks.
Thank you so much, Isabella. We've collected a lot of questions from the Zoom and the YouTube chats, but I think because we've been going for an hour now, what I'm going to suggest is that we have a 10-minute comfort break, and then I will put the questions that have already been asked to you, and then we can open up for further questions. So if that's all right with you, I'm just going to ask all participants if you can be back at 11:50. So that's in 13 minutes time. We're going to start promptly with all of your questions. Thanks. Hi, everybody. Welcome back. I hope most people are back, but I think let's kick off with the questions. Isabella, are you back? Yes, you are. Great. All right, so everyone, what I'm going to do is I've grouped the questions, trying to link them to the slides so that we can have something to look at while Isabella's asking the question. So I'm going to start with some questions around herd immunity. So some of the questions related to how is the percentage, Lydia asked, how is the percentage for herd immunity decided on? Is it based on the adult population or is it based on the overall population, given that only adults are being vaccinated? I think that's...
Thanks for the question. But so the calculation of herd immunity does not have to do with who is going to get vaccinated, because it does not apply only to vaccines, in the sense that it depends. In the formula, what is used is all the susceptible population, which means all the population that is susceptible to the infection, to the agent. So which means in this case, we saw that for SARS-CoV-2 is all the population which is susceptible. And anyway, is all the population, because as I say, the herd immunity ascends when you are in a community, so in a specific place. So you get protected if you are in this community because the others are protected. But as soon as you are not in the community anymore, you need then to see what is the protection in that other community. So we see, for example, this with a lot of outbreaks, that they happen what we call in close communities or in as clusters, for example, some religious community or community where there is not trust on vaccines, or vaccines are not given because of beliefs. Then in this case, we see, for example, that all the population is susceptible. So as this person, one person from this community goes in a school with anybody else is vaccinated, is protected. But as soon as the virus gets into this community, everybody gets the virus because are all susceptible. So it's calculated based on specific characteristic of the pathogen. So in this case, it's SARS-CoV-2, and on the susceptible population. And the assumption is that the vaccine is effective in avoiding transmission. That this is what we don't know today for the candidates we have. Mm-hmm. But because of lack of data, this information will...
Sorry about that.
Yeah.
Sorry, go ahead.
No, this, so it really depends. The information is not available for this vaccine today, but lack of evidence doesn't mean evidence of absence.
Okay, so we're basically doing the best with the information we have and making assumptions that in South Africa, we're aiming for 67% of the population, and that's 67% of the full population, not just adults or a particularly susceptible group. Okay, thank you. All right, so the next questions related to this process of development, because obviously there's a lot of uncertainty, particularly when it comes to starting phase 2 before phase 1 is over. Lydia asked, does that not impact how safe it is? And also there was a question about, given that phase 4 is about the kind of niche potential side effects, and we haven't even gotten onto that with many of the COVID vaccines, how certain can we be, given this shortened process, that these vaccines are in fact safe and efficacious?
So may I share my screen, because I didn't show a slide, because I already give you that by PowerPoint with the slide I show, so I didn't show all of them, but I will give you indeed. There is a slide which is, I think, very useful to answer this question. So can you see it?
Yes.
So I didn't want to get into the specificity of the vaccination of the trials, but so why this was possible? So first of all, a lot of administrative paperwork we got rid of it. I mean, they really avoid to all the administrative part, all the delay between one phase to the other to get the approval, to get even the material needed, again, to get the cases. This was not an issue here. So you see in phase 1, you have really small number of people healthy. So what you see, is the vaccine safe? Does the vaccine seems to work? Are there any serious side effects? So they look really how the size of the dose related to the side effects. So it's really a really specific question. So you don't need a lot of time. So they don't ask the question, are they long-term side effects? No, you just want to know the side effects when you inject your dose. So you need to wait 48 hours. I mean, 72 hours. And then was not an issue to get 100 healthy volunteers. In many trials, they test the vaccine in health workers that are usually healthy and young. So, and then in the pandemic, as I say, the virus is circulating, so it was very easy to see it. Phase 2 is several hundreds volunteers, not an issue to enroll as well. What are the most common short-term side effects? So this adds up to what is already known about safety from phase 1. How are the volunteers' immune system responding, which means they will get a blood sample before vaccination, the day of vaccination, 1 week, 2 weeks, it depends on the trial. And so you don't need time. I mean, they will continue to get after, but then to start phase 3, you need to know that it's safe, and you knew already something from phase 1, and you need to know that from the first sample you get, the 1 week after, you already have an immune response. Then you will study further about it. So as you see, it's not going to compromise anything, because if you are in a pandemic where you have a lot of cases and you have everything needed, this is going to go very fast. The main point is not for the candidate is the case. You see, now we have more than 300 vaccines in total. I'm saying only few. In few months, we have the result only for few of them. So others for which we didn't have the preclinical are still in the preclinical. So if it was true that we have really, let's say, avoid or jumped some of the steps, we will have also candidates already in clinical without going through the preclinical, which is not absolutely the case. And no regulatory body will never approve a vaccine for which we don't have all the results for all the phases. So this is uncommon, it's the first time, but this is going to change the story of vaccine development forever.
So it's not so much that this is too fast, but it might be that previous processes have been slower than they need to be, and that we've been able to learn from previous vaccine development experiences to speed this process up.
Indeed. As well, because there was a lot of interest, political. So with MSF, we intervene in many places where there is not a lot of interest for, the international community. We see people dying of rare diseases for which a vaccine will never be available, just because we need probably even more time to just make the point that a trial needs to be started, But in this case, everybody wanted a vaccine. For this, I put the picture of the little princess at the beginning, prince at the beginning, just to say, because everybody dreamed about a vaccine. And now that the vaccine is available, we have a lot of doubts, which is good. Questions are always good. Yeah, but the problem is that the source of information that the people use to answer these questions are not good.
Yeah. Okay.
I will stop sharing. Yeah, good.
I think I've overridden you, so I'm back on my screen. Thank you. All right. So the next slide. Sorry, I'm just trying to. There we go. Oh no, wait. All right. So there were a few questions about this slide. In particular, the question was about this mechanisms of vaccine, vaccine impact. And what you said is that the COVID vaccines so far what we know is that they prevent or reduce infection. So that's infection in the person who gets vaccinated. It prevents and reduces the degree of severity of disease in the person that gets vaccinated. But we don't know if it prevents or reduces infectiousness. So we don't know if my being vaccinated decreases the chance of my passing COVID on to someone else. So given that, how can we be sure about herd immunity? Because part of the point is that the person who gets vaccinated is supposed to be able to protect other people. And there's just quickly the second question on this slide is there's something under many unknowns about all or nothing versus leaky vaccine. What is a leaky vaccine?
So I think leaky vaccine was because they understand me talk about live vaccine or leaky vaccine. The question about what is the question? Is it a leaky vaccine?
What is a leaky vaccine? It says many unknowns, all or nothing versus leaky vaccine. And we just don't know what a leaky vaccine is.
So the point is, to answer the first question, is a very good question. The answer is already there, in the sense, the point is the herd immunity is based on theory, and then on an epidemiological formula that we usually calculate the herd immunity disproportion for all the vaccine, because you need this for your vaccination program. But indeed, I say that the assumption is that the vaccine is effective against transmission. So if for the knowledge we have today, we don't know if the vaccine is effective against transmission. But indeed, still, we need to calculate the herd immunity based on the assumption that it is, because vaccination program needs to have a target. So, for example, we know for measles, we know that measles is effective against the transmission, that we need to reach more than 95% of the population in order to have everybody protected. And this is how we base our vaccination campaign, our calculations and everything. So government needs to have a target in the program to know also how an indicator of performance. And then, as I said, it's very likely that this vaccine have an impact on transmission. Also because if you are not sick, you are less likely to transmit. So it's just because reading the report that have been made available, public, you can see that actually the issue is that the numbers are very small. So it means that then the confidence interval is very large. So which means you cannot trust these numbers because are too little cases. But as far as the trials goes on, and then you will have more cases, then you can, for sure, have the information. We can have the information we are looking for.
Okay, I think I get that. So we can't, so herd immunity isn't an absolute certainty, and we don't have the information to show exactly how many people need to be vaccinated for herd immunity, but there's a good chance that individuals being immunized will reduce infectiousness, and so we're aiming for a certain percentage of the population for herd immunity, because we think that's likely to be the kind of magic percentage, but we don't have evidence at the moment that it'll certainly result in herd immunity.
Yes, indeed. I don't know if this is clear for everybody.
Maybe if there are further questions on this point, we can bring them up during the oral question time.
Okay.
Is that all right?
Yeah.
Okay. All right. So
the other question was about leaky vaccine.
Yes.
So leaky vaccines, to my knowledge, is related to not to humans, but is related to study in animals, where there was a theory that they showed that they could stronger virus they can allow to develop leaking vaccines. So which are a vaccine which can allow a stronger immunity, but to my knowledge, there is not at all a relation with the COVID-19 vaccines. In my work, I haven't seen anything for humans, but this was indeed studies in animals, so in the veterinary world, we can say, and so it's studying chickens, I think.
Okay.
Yeah. But
Okay.
yeah, so I'm sorry, I don't know anything related to that with COVID-19 vaccines.
That's fine. We don't want leaky vaccines.
I can study this and write you a reply for that if you want. I can do a literature search.
No, it's fine. It was just because it was on the slide. Thank you. So the next question is about these mRNA vaccines, and you didn't speak too much in detail about the different platforms. But there's been a lot of controversy about mRNA vaccines in South Africa and I think around the world. And you spoke briefly about how the same kind of technology has been used in relation to cancer research. And I wonder if you could just speak to us in a little bit more detail about the mRNA vaccines. Are they changing our DNA? Does it change the very fundamental of who we are? Is it dangerous in that way? Just give us a little bit more information about that.
I knew this question was coming because it's a question we all have. I mean, we all get, and then the social media, they don't help at all, I think, in this confusion. So I put the link of a very nice, I think not in this one, but in the other one, of a very nice short video. It's the video where I took the picture to describe the immune system. The video is 4 minutes, and the second part of the video, they really explain well about the mRNA vaccines and how they work. So quickly, just to say, our genome is like a library, okay? It's our library, and we have then there written everything from who we are, what we can do, the diseases we will develop, or etc. Then each page of this library is, let's say, can be read, is indeed the message that there is. The idea of the mRNA vaccine is to take one part of the virus, which is the spike protein, and then to make this synthesized by our own cells. How they do this? So they give a message to the party cell in our cell able to develop proteins, and they develop these proteins, that they are the spike proteins. So there is no virus in the body. We cannot get sick because there is no virus. There is only the small spike you see there. And then the immune system, so our cells are going to read is a photocopy. So they will send a copy, our photocopy machine, our printer will print this copy. This copy will be released by the cell, and then the immune system, what we saw, we see the intruder, which is not a real virus, but it's just the spike. So they will develop the immunomemory. What will happen? They will destroy the spike protein, but they will destroy also the RNA messenger because it cannot survive. So the memory, I mean, there will not be a recall of the RNA message in our body or in our cell. There won't be recall of the spike protein. What will remain is only the T cell, which is T memories. I mean, it's the lymphocytes that are going to be able to produce antibody and to attack the intruder as soon as they will see it. So there is no way a messenger RNA can enter the DNA chain. There is no way, because it's like if you want a copy to get into a book. Can you do that? You can't. Yeah, because you have already your copy. They are written in 2 different languages, just because one is the RNA and the other one is the DNA. So there are steps which are needed. We don't have the possibility to do it on the way back, you know? So it's really a new technology, very smart, also because they can be produced very quickly. This is the reason why we have them today, and we don't have other for which the production takes time. And then also, really the idea is to have very little side effects, because actually you side effects linked to the excipient of the vaccine, which are there for sure. So the pain, the swelling, etc. To have the fever, because usually we say that it's a good sign, because it means that your immune system is reacting, no? I mean, all the doctors, so also all the, let's say, not traditional medicine thinks that fever is a very good sign. They even say not to treat it, because actually is a proof that your immune system is working. Yeah, so I think we also say usually fever is fine, it's not an issue. Most of the children, they get fever when they get vaccinated. So, but then it's going to self-limit and you don't need to do anything about it. So I hope I explained the mRNA vaccine. They don't change our DNA. I'm not going to get blonde if I get a mRNA vaccine. They don't change who I am, because there is not, it's not possible for the knowledge we have today.
Okay, that makes sense. So they're kind of the messenger, taking the thing that your body needs to create the T cells, to create the immunity, and then they disappear. So it's not like the mRNA is remaining in your body. It's just a method of delivery, essentially, if I understand you right.
Also because it cannot remain, because it's very unstable, it's very fragile, and it's going to be destroyed, but also because it cannot get into the mechanism of our body, if not to tell just the ribosome to produce this protein. The protein corresponds to the spike protein. So it's just a way to have the copy of something we don't have in our body, because we don't have in our DNA. But they introduce this and they allow them produce something that they want, and that's it.
Okay. Okay. Thank you. That makes sense. If there's further questions on that, I'm sure they'll come up. All right. So the next question was about efficacy. There are different efficacy levels. Sorry about that. There are different efficacy levels for different of the vaccine. And what the question from Julia was what the different efficacy levels mean. So if it says that there's an efficacy of 95% or of 70% or whatever, does that mean that it works in 70% of people who receive the vaccine, or what? And then how does that compare to other vaccines for other things? What are the kind of efficacy levels we expect from other vaccines, that, like childhood vaccines, yellow fever, etc., that we take? Okay, so
very good question. I didn't show this, but then, as I said, no vaccine is effective 100%. So knowing this, that we know our expectation is, well, I would say 99% in the optimal situation. There is no vaccine effective 99% in one dose. We know, for example, for measles vaccine, that we can increase a little the already excellent efficacy of the vaccine with a second dose, for example, and to get to 99%. But we could say, if we take measles as an example, which is one dose 95% in people older than 12 months, because also the age is important. In older people, for example, above 70, also the immunity, let's say, the immune system is weaker. So probably somebody believe that you may need more doses, etc. So let's talk about healthy individual. Yeah. So above 1 year of age and let's say below 70. Yeah. This is a range I give like this, just to say that they are healthy. In these individuals where the immune system can really react quickly and is in good shape, then the vaccine efficacy is the value we get from the trials, which means is a calculation. How many people vaccinated develop the disease compared to the number of people not vaccinated that develop the disease. So it's a proportion. Yeah. So which means that is 75% means 75 individuals on 100 vaccinated didn't develop the disease. Yeah, so the denominator is the vaccinated. And indeed, there is always a confidence interval, as I say, so which means the low limit, the high limit. And this is also very important. I didn't report them here, so won't be very nice for an epidemiologist. They will attack me, they will say yes, but because was not needed, in the sense that anyway, these are very valid value, because they are not valid, for example, when the interval is very large, when they cross zero. For example, if I would say 95%, less than 10 and 110. You see what I mean? So this doesn't make sense, because it means then it's not a valid value. But due to the fact that all these intervals are valid, I just put the absolute number, which is enough. And so the efficacy is a theoretical number we get from a trial. Now, what we really look for vaccination is effectiveness, which means, is the effect the real effect in the population? So what I was saying, there we don't consider anymore only above 1 and below 770. We do consider everybody. We do consider not all the healthy. We consider comorbidities. We consider, for example, people with problems in the immune system, people with chronic diseases, old people. So which means this value, theoretical one, is going to meet the reality in a population, is going to give an effectiveness, which is usually lower than the efficacy. And so we use, as an example, the measles, because it's one of the most effective vaccine, 95%. So the Pfizer vaccine is excellent, indeed, if we see these results. And usually also WHO give the characteristic of the product, so the minimum interval they will accept. And for the COVID vaccine was 50%. So which means they are not going to approve any vaccine to give a positive, let's say, opinion about any vaccine that for which vaccine efficacy in the trial is less than 50. So it means then less than 50 persons who get vaccinated are going to be protected. This was the minimum value given by WHO when they is the product profile is called, and then it's given every time a new product is developed. It's like this is our recommendations to the companies. That said, the regulatory body may have different ranges, yeah, but WHO give what is the standard for their approval. And you see, for example, the CoronaVac, the last one on the right, the study in Brazil, they show 50% efficacy, which may not seem very good, but is the minimum to make this product considered by WHO, let's say.
Okay, yeah? So the top end of the Oxford AstraZeneca efficacy is 90%, which means 9 out of 10 people getting the vaccine won't get the virus. We can expect that to be a bit worse in reality compared with clinical trials, but it's still very high. That's still very efficacious. And it compares quite well with the measles vaccine. But what about other vaccines that, you know, is 62 to 90% pretty good for a vaccine?
Is 62 to 90% is good. The problem is that you need 2 doses, 14 days apart. So this number is a number of 2 doses, okay? Then we compare with measles, which is only 1 dose, the 95%. Then we can compare also, for example, with tetanus vaccination, for which to have a long-term protection, you need on your life cycle at least 5 doses, and then you need this boost. So you see, and then, but you talk about efficacy with a different number of doses. So for the COVID vaccine today, we have all the vaccine you have in the table have more than 1 dose, 2 doses. And this efficacy is calculated 7 days after the second dose. It is possible that as soon as the results become available about 1 dose, because also other vaccines are trying to do an analysis in the subgroup who got only 1 dose, we may see some protection. I don't know if you heard, but in Europe, there were some rumors about the willingness to use only one dose to allow more people to get vaccinated. But then they saw there was a need, there were immunologists, they were looking into that, and they saw that actually they won't advise to do this unless it's really needed, because anyway, the results we have is that with 2 doses, very important, they don't want to delay the 2 doses too long. So they do advise not to delay the 2 doses for more than a few weeks, because the results, they use this interval. We don't know.
So it's important that we're following what the trials followed, because that's the only way we can be sure that we'll get the results that the trials got. Thank you. And then there's quite a big range of prices of the different vaccines, and that's very controversial in South Africa because we're not sure what prices we're getting, and there's not very much transparency about that. We won't go into those questions, but it ranges from $3 a dose to potentially $37 a dose. How do these prices, obviously it's difficult for you to answer this, but how do these prices compare with prices for other vaccines? It seems to me like they're probably quite a bit higher than some of the basic vaccines, but maybe not some of the adult vaccines. How do they compare?
So this is a very good question, difficult to answer. Why? Because so usually the company, they have a price for high-income countries, and then there is, in low-income countries, the vaccines are provided through very complex mechanism, and then what the low-income countries pay at the beginning of the implementation of a program is lower than what they will pay after. So usually the price is lower, but the budget comes from donors. Usually, I don't want to get into too much details, but just to say that then it's difficult to compare the price of a vaccine implemented in the low-income countries because through this mechanism to the price in a high-income country. The problem is then after the implementation, the low-income country will need to pay very high price. So to maintain, the program and the vaccine. One example I can give you is the papillomavirus vaccine. So the HPV vaccine is a very good vaccine. We know very important in people living with HIV, and the cost in Europe is €80 per dose. The dose we can pay through Gavi, so in low-income countries, is about, let's say, $7 per dose, but all in the implementation. After this country, they will need to pay the full price, which is indeed $80. 80 euros is not at all the same in Europe and in a low-income country. So just to say, it's very complex mechanism. I'm not an expert of access because it's really behind my capacity as a doctor, but I've been working with vaccination a lot, and I know this is a big issue. And with MSF, we do try indeed to avoid the lack of transparency, because it's very dangerous, and there is not reason to not be transparent. And indeed, the fact that now there is this lack of transparency raise a lot of questions about these deals and what are the reasons behind the final price and the negotiations done in one country and in the other. But just to say, then to compare with the measles vaccine that we use in our campaign, the cost is less than $1 per dose. And to compare, now you can compare with the AstraZeneca vaccine, the mRNA vaccines, which are extremely expensive.
Okay, so there's no standard, which is part of what makes this so difficult. All right, so now there were quite a few questions relating to who's considered to be high risk and who for COVID, and in particular, who should be getting the vaccines. And so I'm going to try and ask a bunch of those questions, and I hope that I get all of them right. So the first one was from Caressa about detectable versus undetectable HIV and differences in viral load. I think in some ways you answered that, in that there's no contraindication for people with well-managed, and presumably by that you mean undetectable or low viral load HIV. But for people who are not stable on treatment, we don't have data on that. So we don't know what the impact of the vaccine on those people will be. Am I right there?
Yes, you're fully right. So usually we say the definition of stable, no? Well-managed HIV, usually in the definition there is undetectable viral load, which means that the treatment is working, and then everything is going as it should. There is not resistance, etc. The adherence is good, etc. Then when I say that there is no evidence, it's not evidence about safety, but also about efficacy. In the sense, it's very likely then if the viral load is not under control, then also the immune system is affected, which means it may be less able to react and to develop an immune response. I think we are more concerned for the vaccine we have today, then it may change with other vaccines. I'm more concerned about efficacy than safety, actually. But the doctor that is taking care of the person will know perfectly well what is the balance, between the risk and the benefit for the person during a pandemic, depending on the epidemiological situation and the work of the person. Because also, for example, now there are many health workers, they have also other comorbidities, like also HIV. So this will need really to be thought carefully about the person.
Okay. And then somebody asked, Andile from the YouTube link asked whether the vaccine works if your immune system is very weak. And I see that you've got immunocompromised people. There's a lack of data on, but if you've just got a particularly weak immune system, is the answer the same, that the doctor will consider whether it's worth vaccinating you or not? Yeah.
The problem is, as you can understand, immunocompromised people were not in the trial. And so we don't have data, and we can base our conclusions on assumption or on what we know of other vaccine in immunocompromised. That's it. So okay. I think it's really the lack of data. For this, I wanted to be clear about contraindications versus lack of data.
Yeah, that's important, because it's we didn't test everything in the trials. But in South Africa, in the AstraZeneca trial, at least, people living with HIV were included in the trial. So there is data here, and that's part of the reason, as I understand it, that the trial happened here. Was because of our population of people living with HIV. So we are getting that data, as I understand it.
Soon, I hope yes, indeed. Unfortunately, when I look, so we were very happy. I mean, like some scientific community, to see that there were also trials ongoing in Africa and not only in other continents, because also, we wanted to be sure that there is no difference in ethnicity, let's say, also in the response. And also, indeed, what we were saying about, indeed, all the possible factors we may impact efficacy. And indeed, the question about HIV was there since the beginning. And I think it's great that South Africa was one of the countries where the trial was done. But as you know, the trial is still ongoing. So we have data, but are very small. And I believe that they do prefer to have solid evidence before publishing, which is understandable. Is preferable also to avoid, confusion. But data will come thanks to South African data, thanks to the trials done.
Okay, that's great. So there were a few questions about if people have recovered from COVID, whether they need to be vaccinated, if people have active COVID, whether they should be vaccinated. And I see on your slide here that it says you should avoid vaccination in the acute phase of the disease. So if the COVID's active, but if there's a previous infection with COVID, you do still need to be vaccinated, or you can still be vaccinated. And somebody asked, I think Tommaso or Neo, I'm not sure who, asked, would you have the same dose? If you've previously had COVID, would you have the same dose of the vaccine as everybody else?
Yes, so one of the concerns of the scientists was indeed the safety of the vaccination in these people that they had. So this could somehow compromise or cause a worse disease. And then indeed in the trials, they saw it that it was not true. I mean, there was not risk at all. And this was the main concern. And the data we have, they showed that there was not impact. So it's safe. And in terms of efficacy as well, is efficacious. Why? Because anyway, we saw from the article I showed that the immunity from previous COVID doesn't last long. So they say 5 months. For this WHO, in the recommendation they give, for example, about Pfizer vaccine, they say that the person with the previous COVID should be vaccinated close to 6 months after the infection, because they think in a context of shortage of doses, these doses can be left for somebody who may need them more.
Okay.
But,
so, yeah, sorry.
No. But as I said, in Europe or in countries where the vaccination is going on, there is no screening done previous vaccination.
Okay, somebody asked that. So there's not going to be a COVID test as you go and get your vaccine. They will vaccinate you sort of regardless, as long as you don't have contraindications. And pregnant women, I mean, pregnant women weren't in the trials, because trials never happen on pregnant women because of the possible effects, and yet they are at higher risk of COVID. Are we going to get anything more about that when further trial data comes out?
I don't think, in the sense, so this is the issue, vaccine or drugs for pregnant women. I mean, it happened to women to be accidentally pregnant during the trial. So they didn't plan a pregnancy, but between one dose and the second, they get pregnant during the 2 years of follow-up. So for sure, we will get some that got pregnant, and thanks to those, we will be able to have some information. But as this was not planned as a primary endpoint, it will never be in any trial, then indeed we are not going to have strong evidence about it. And but again, it will depend, for example, also on the phase 4. If, for example, if somebody, scientists, institution, they will decide to target with vaccination pregnant women, they will decide, for example, to do a study on this, and then they will allow us to have more data. So this is possible in a phase, let's say a phase where the vaccine are rolled out, so are available in the country. And for, I think, one category which is even more interesting, the pregnant, is the lactating woman. Why? And then for this, we managed to get some answer from WHO for Pfizer vaccine, at least, because at the beginning, indeed, pregnant, okay, you are not part of the group at risk, in the sense you are not working at the front line, usually, when you know you are pregnant. But you are lactating, maybe, and you are working as a front line working. Yeah. So what should this woman do? Should renounce to breastfeeding, or should get vaccinated? It's an important question, and this may be big numbers when we talk about middle or low-income countries where breastfeeding is more common. So for this, we had these questions, and we got some answer from WHO, from the expert, in saying that there is so far no evidence. Also in the preclinical studies, so in animals. And then, but again, we don't know, we don't have the data to say if there is a risk for the fetus. So there is a choice, again, done case by case, because there is not the evidence, but there is reassuring information, so from the experts. And I think, anyway, as always, at the end, is the personal decision of the of the person, unfortunately. But just to say, then it's more complex than just pregnant.
Okay, thank you. So we're almost at the end of the written questions, and then we'll open it up for oral questions. We'll try and make these last few a bit quick. The last question on this slide was, given that there's no contraindications for people with diabetes or cancer or stable HIV, do we know about the impact of the vaccine on other medicines that people may be taking?
Yeah, so this I look because it will depend indeed in each vaccine. I cannot answer in general this question because, as you know, I don't want to lie to you. It really will depend, as each vaccine is specific. And then I, as a doctor, I would like to see the company to tell me that there is not interaction, or I can take myself a decision. So far for the Pfizer, AstraZeneca, there is not. They say there is not interaction with other drugs, but also, for example, with other vaccine, they do advise to wait at least 15 days between a vaccine before and after receiving COVID-19 vaccine, because there is, we know that we can, for many vaccine we have, we know we can give them at the same time without not issue. For the COVID-19 vaccine, we don't have the evidence, so we do prefer to wait 15 days. And then for the drugs, really, I think we need to rely on the product insert that is going together with each vaccine, because it is impossible for me to answer the question in general for all the candidates vaccine.
Okay, but the indication so far is that there isn't interaction, but we've got to wait for the product inserts to know whether and the extent to which there would be interaction. Okay, thank you. And then I think two more questions. The first is about our variant, the South African variant, or the new variant, if we don't want to call it the South African variant, which I think we don't. Will the vaccines work on it?
This is a very good point, Sasha. We say, so as we don't call SARS-CoV-2 the Chinese vaccine, we should not call the South African virus. I fully agree with you, because yeah, it's or South African virus, etc. As I say, mutation, they happen all the time in viruses, all the time, really. And we saw this coming. We were expecting these variants, and it made also a hypothesis about that. So as I said, before yesterday, when the Moderna press release came out, the experts, they say that very likely there is no impact on mRNA vaccines. So I have this also in a slide at the end, if you want to show, or I can show. I put it because I say I will share with the participants. If you go downstairs, here, that one. So if you see this slide, I don't know, so you see that summary of functional impact of key mutations. So you see there are the South African, the variants identifying South African in Brazil and UK. So there are on the right of the table, you can see the functional impact, which means real impact on the behavior of the virus or the transmission or the pandemic. And then you can see there is transmissibility, which we know today for the South African, UK variant, the Brazilian is higher. So there is an impact. The variant is more efficient in transmitting. Then also therapeutic monoclonal escape, which is indeed has been tested against the monoclonal antibodies or recovering people, which is one of the optional therapy, experimental therapy. And then also polyclonal escape, and the last one, impact on vaccine efficacy. As you see, the color yellow means a potential impact, and the green, no impact. So if you look at the variant we talk about, B1351, the South African variant, so the experts, they believe that there is no potential impact from the mRNA vaccine, because the vaccine, they are today broadly distributed. But so what they need to do is, as Moderna did, is to actually test the blood of recipients, so the people who got vaccinated, against the variant. to really see if this neutralizing antibody, which are those that matter, actually those that we really allow to have a protective immune response, are still effective. So this, I put it here just to show that there is an evidence which is changing.
Yeah, and the AstraZeneca one?
It is not there. So because indeed there is no, AstraZeneca has been used a lot in UK, where the UK variant is, we know, and then there has not been so far any claim from any article published and nothing about that, but I'm sure we will know very soon, because this is an issue which is, I think, now a priority for everybody. So the point is, as I said before, so these vaccines are all developed for the spike protein. So only the mutation that they happen on the spike are going to affect these vaccines. This is already something very important. If the mutation is not on the spike, there is not even reason to think that there is an impact.
But this is the South African variant has impacted the spike.
Yeah, and for this they test it. Yeah.
Yeah. Okay. So we're waiting to hear from AstraZeneca, depending on their tests, as to whether it should work. The indications I've heard elsewhere suggest that there shouldn't be too much of an impact, but we need to wait for the science.
Indeed. And also because new variants will come, unfortunately. So I think every time we have an answer, then we will have a new question. And this is what I think what is good for me of the vaccine that can be developed quite quickly, like the mRNA vaccine, that if it's true that then there is a resistance, then a new vaccine can be developed quickly and then can become effective.
Okay. All right. And then just the last written question was about from Lydia, and it was about whether it is whether it's a internationally enforced practice that only governments can purchase vaccines rather than the private sector or NGOs or anyone else.
I mean, not at all, in the sense that nobody wants this. I mean, I don't think that it was a decision, like who is going to purchase. The point is that many countries put money on the development of these vaccines. Company started developing vaccine at no cost, almost some. And then somehow there was a deal even before starting producing the vaccine, somehow, a political commitment. So I can assure you, we are not happy at all not to be able to purchase the vaccine one day. There is a lot of movement internationally trying to make all the process more transparent and fair. And I'm sure we will see soon as well a change on this, because there is a lot of pressure. So I think also the fact that the African Vaccination Task Group manage is very good, because you see there are different bodies all fighting for the same. I think somehow there are people that they think that this is going to jeopardize somehow the COVAX mechanism, but we know that the COVAX mechanism is actually weak. So we need to find for alternative solutions. This is the reality. And I'm sure after Andrew will be able to tell more. He's also wrote that he can provide more details about prices, all these aspects.
Okay, great. Thank you. All right, so everyone, that's I hope that we've managed to cover the questions that were written in the text. I think we've got another about 20 minutes for oral questions. If you'd like to ask a question, I ask that you put your hand up and I'll call on you. And if you can make it as brief and efficient as possible, so that we can get through as many questions as possible. Isabella, you put up your hand.
There is one question I saw quickly. Sorry, I missed the answer probably. But if you get vaccinated, you need to quarantine yourself, or if you indeed you can infect others and get infected. Indeed. Yes, good question. So the protection starts after the second dose. So you anyway, even after the second dose, you need to continue to respect all the barriers, because as we say, there is not protection, which is 100%, and we don't know the impact on transmission. So yes, but you don't need to quarantine yourself. You just need to respect what you do now, to have exactly the same practices.
Thank you. Sorry, I missed that one. All right, do we have any further questions from participants? Please stick your hand up. Don't be shy.
Also, because I want to hear your voices to see you. I'm just myself as Sasha, which is great. She's beautiful, but it would be nice to see you as well.
Absolutely. Any more questions? There was one question that, oh, sorry, Julia, you go ahead, please.
Sorry, I was muted. Can you hear me? Thank you very much for the presentation. It's been absolutely fascinating. I'm learning a lot. This is kind of a logistical question, because most of the vaccines that we're procuring have 2 doses. If we can't get the second dose of the vaccine to everybody who was vaccinated at first within those 4 weeks, does the immunity kind of disappear? Does that mean that the whole kind of program was for nothing? And does South Africa have the capacity in its health system to reach everybody twice within 2 weeks? Thanks.
Excellent question. This was indeed the reason why in Europe they told to just give 1 dose and then to see if it was easier. Also because we know for some communities like migrants, it would be very difficult to be able to reach them twice, or other difficult communities. So as MSF, we are really looking into that, how to be able to achieve high coverage with 2 doses. So just to say then, I think this is what the now programs are looking into carefully, to be sure that they have enough doses, 2 doses for the group they target. One example, in Belgium, there are 2 vaccines now, Pfizer and Moderna. I saw that they're giving Pfizer to one group and Moderna to the other, probably because they calculate the number of people that they are targeted by one and by the other. They want to be sure they don't mix up the vaccine, because today the recommendation is not to give 1 dose of a vaccine and then a dose of the other, but to complete the schedule with the same vaccines. And then there is indeed this recommendation on not to mix even for the mRNA vaccine, to get the same. So I believe that the programs are really looking into to be sure that they can guarantee for the target group 2 doses. And this is the most challenging, because they may have doses to start a campaign, but not to guarantee the 2 doses. So then I think in MSF, we learn this very well. You should not start if you cannot guarantee full coverage. Because if you start, then as you said, Julia, you will get into trouble, because you will realize you don't have enough doses, and then your first dose may be completely waste. Because if you are going to be able to vaccinate after 6 months, is the first dose still good? We don't have this answer, because again, we have all information for short time now. But anyway, WHO really recommends not to delay too much, more than 6 weeks between the 2 doses, at least for the Pfizer, for which they have expressed an advice. Thank you.
Thanks, Julia. Thanks, Isabella. Are there any further questions? I noticed that I missed one question, and it relates to a question from Toko, or it's similar, and that's about whether people will need to quarantine between shots or take any other steps, or do anything different to what we're doing now between vaccine shots.
No need, not at all, apart to be vigilant for side effects, to report them. This is very important. It's what I tell all my colleagues that they got vaccinated, that really if they have even a small side effect, it's very important to report, because we need to have the full data for this phase 4, even more if it's something rare or odd that we haven't experienced before, is very important to report. But that said, they are vaccinating now health workers while they are working. So the same day, what they need to do, and this is very important, is to watch the person, to observe the person for 30 minutes, we say. It depends on if the person is is part of the precautions, the precautions for sure 30 minutes. In some places, they observe the general population without any precautions for 15 minutes, which I think is quite short. So 30 minutes is good. What is very important, I think, because they are talking if to allow pharmacies to give the vaccine or as well in the pharmacy, etc. I believe that vaccination must be done in a place where it's possible to manage a severe side effects. So I don't have any issue if they want to put it in the pharmacy, as far as then the pharmacies are able to manage an anaphylactic shock. This is the point, because it's extremely rare, but again, as I said, we don't accept any damage for a healthy person from a vaccine. So we should avoid as much as possible anything.
Okay, thank you. So it's just kind of taking sensible steps and making sure that both individuals who are being vaccinated and the system puts in place these sensible steps to make sure people are safe. Thank you. Spongile, go ahead.
Hi everyone. My question, it's more of an advocacy question. As we know that the pandemic has affected everyone, especially globally. So in my mind, I think it's not fair for a vaccine to be about $3 to $7, especially for countries like South Africa with 54 million people in the country. That means then maybe we can be able to buy the first dose, but the second dose, then it will be difficult, knowing that how things are done in South Africa. So I just think here to say, as South Africans, I think maybe if we can, as the world, not as South Africans per se, as the world, if we can find to say how much is to produce one dose, so that we can be able to make an argument out of that to say it cannot be that 3 doses or $4 to $7 and then per dose, then that is too much for me, because I think we cannot, especially for poor African countries and middle income African countries. Thank you.
I cannot agree more with you. I mean, there is nothing I can say apart that as MSF, we have a group access campaign that has been working, night and day to try to really to discuss this for all the humanitarian actors, and indeed about the price. But I think the citizens are really needed everywhere to also raise their voice, and then to show actually that until when we are all safe, no one is safe. And this is something has been clear since the first days of this pandemic. For everything, and for vaccination is indeed the role.
Thank you. Munyana asks, is it likely that the vaccine dose will last a lifetime? That mirrors another question. How long does the vaccine last in your body? Are we going to need to do these every so often, like a flu jab every year, or more or less often than that?
I'm sorry, I cannot answer this question because it's for the moment it's just theories and speculation. What we know, we saw the virus is mutating. We know it, and we were expecting this. Then the impact of this mutation on the vaccine are unknown, as we said before. So flu indeed is different. Influenza virus is different than coronavirus, and if we are going to get at the same level where each season a new vaccine needs to be developed, I think it's too soon. Now we have to control the pandemic. I mean, really, and I can understand this is an issue because I say, I don't want to get a shot every 6 months. We have to trust science, and I'm sure nobody will be happy, apart the companies probably, sorry, but nobody will be happy to sell a vaccine every 6 months. So I'm sure I fully trust the regulatory body, the decision they will take, and the experts. So one step for the moment, I think the most important is really to make the vaccine available to everyone. At least these 2 doses needed, hopefully one, if a vaccine with 1 dose will become available. And then, we will start from there, you know? So I'm sorry, I don't have an answer to that.
We got another question just now through YouTube, and that's what happens if you contract COVID between the doses?
It happens that is possible. There is, will be not the first time that somebody gets a disease in the window period we call between the vaccination and the immunization. What I say at the beginning, so you get vaccinated, but still your body needs to mount the immune response. So there is a window that we call is 7-10 days according to the vaccine. So it's absolutely possible. It's possible you were incubating SARS-CoV-2 the day of your vaccination. You didn't know because you didn't have any symptoms, and you will start developing the symptoms after. This is not because the vaccine was not effective, it's just that the vaccine was too late. I mean, this is how it is. Also, if you get infected during the window period, is the same. And still, don't forget that even if vaccinated, you are not protected 100% by the vaccine, because no vaccine is effective 100%.
And so then would it be for the doctor, your doctor, to advise you on whether you should be taking the second shot or extending it so that you're not taking it while you have active COVID?
Yeah, this question allows me to answer another question that we get often. We didn't ask today. So the PCR test result, the antigenic test, are not affected by vaccination. So at least this is the evidence we have today. So if you get vaccinated, you have a positive test, it's not because you got the vaccine, but it's because you have a SARS-CoV-2. So this is important also because sometimes people, there have been also rumors about introducing the vaccination card, the passport, is how it's called. And then people may get the question or the doubt, but then if I get vaccinated and I need to travel, I need to test, is this a false positive? No. Anyway, we discourage to travel just before the vaccination, because it's very good for us to wait for the side effects, so not to travel the day of vaccination or the day after, but still to have time to have a good immune response if you had your pain or fever the 2 days after vaccination. But then there is no cross, let's say, reaction between the vaccination and the test results.
Okay, that's important. Thanks. We have time for one more question before we move on to Andy Gray's section. Is there anybody who has a last burning question? Please stick up your hand if you do. There was one final question on YouTube from Pumeza, which is about whether there will be separate vaccination sites or whether it'll be integrated into the service, and I'll answer that. It's not 100% clear. It looks like there's an intention to integrate vaccination into our normal health service. So vaccination will be provided at health facilities, clinics, hospitals, as well as GPs' offices. We know that Dischem and Clicks have offered to, which are pharmacy groups, have offered to be part of the vaccination rollout. We also know that there's an intention that occupational health services like mining hospitals and that kind of thing will participate. So it seems like they're going to be integrated into the system. Of course, for us, we know that our system's already overloaded, and so we wouldn't want this to create extra burden on the system, and we haven't heard from government how further resources, human and other, will be brought in to ensure that vaccination can happen smoothly and doesn't disrupt other healthcare services. So if there's no more questions, which it doesn't look like there are, I think you've answered all of our many, many questions. Thank you so much, Isabella. If further questions pop up, I hope that we can transmit them to you and then send them out to participants.
I will remain anyway, because I'm also very interested in the presentation of Andrew. And so if there are questions after, they are welcome always.
Thank you. And
thank you.
Thank you so much. That was such an informative and clear and interesting presentation. We really appreciate it. Okay, Andy, over to you.
Thanks very much, Sasha. Let me see if I can share my screen. And there it goes.
We can see that. Thanks.
And you can see it now in full screen. Okay,
Yes.
so I thought I would start, and intriguingly, Isabella and I used exactly the same slide from Nature. A little bit about what would be in a dossier. So when we talk about the evidence that the regulator gets, it's the evidence all the way from the non-clinical studies, so those animal studies that are done, the toxicology studies, and then the 3 phases of studies in humans, the healthy volunteer studies in phase 1, and then the phase 2 and phase 3, which try to see if the medicine actually works. But in compressing this process, a lot of this has become overlapped. So in phase 1, for example, we might want to check for late side effects, even in those healthy volunteers. But without having to wait a whole year, you would start phase 2 after a number of months after the initial phases. And in the same way, phase 2 data might not be complete before you start phase 3. And in fact, we now are registering these products, or at least giving them provisional registration around the world before the full phase 3 data are in. So we know the full number of people have been dosed, we know what their short-term efficacy looks like, and we know about short-term side effects, but there's long-term follow-up in order to see if anything happens up to 12 months after that injection. All of that is then put together to the regulators, but the pieces can also be submitted as they get generated, and that's what is called a rolling review. So where the regulator is getting each piece as it gets finished, and then at the end, the whole dossier will be put together and a decision is taken. So how does it look in South Africa? So we have the South African Health Products Regulatory Authority, which is an independent national medicines regulatory authority. It's located outside of the Department of Health and stands entirely alone with its own board of directors. The decision-making at SAHPRA is vested in the staff. So it's not the board that takes the decisions. In the old days, it was the Medicines Control Council, and it was those part-timers who took the decisions. Now it's the staff of SAHPRA who take them. But the CEO, the Chief Executive Officer of SAHPRA, is able to appoint advisory committees which can make recommendations to the staff. It's responsible for medicines, both human and animal, for medical devices, in vitro diagnostics, and on behalf of the Department of Health, it also looks after radionuclides, which at the moment fall under the Hazardous Substances Act. The most important section of the Medicines Act of 1965 is this requirement in section 14 that medicines may not be sold unless they have been registered if they've been the subject of a declaration. In other words, a call-up notice. And so the possibility was created back in 1965 for medicines to be dealt with in categories as we worked our way through. And it took from 1967 until 1985 to work through all of the human medicines. And since then, anything new has had to be registered before it could be sold. So apart from the complementary medicines, which are being dealt with separately, but including all of the biological medicines, they have all been the subject of a call-up notice. So they all have to be registered before they can be sold. Now, in that section, some of you who were reading it might have seen, except in terms of section 21. And section 21 allows for access to unregistered medicines. There are a number of scenarios that are covered by that. One is clinical trials, and something which is being tested for the first time is not yet registered. So a section 21 approval is implicit in approving the trial. But generally they're for individual patients, or there can be a bulk approval. For example, if the state is unable to procure stock of a medicine, then a bulk approval for importation of a replacement medicine can be made. So what does SAPRA look at when it's deciding whether to register a medicine or a vaccine? By law, it's only allowed to look at 3 elements: the quality, the safety, and the efficacy. So the first is the quality. How is the medicine made? What ingredients are in there? What are the processes? How do we know that consistently each of the batches will look the same? And then importantly, how will quality be assured during ongoing production and distribution? So it's not just a simple matter of saying, we made a batch and this is what it looks like. We have to think about the ongoing quality assurance. The safety, Isabella covered quite a lot of. So we want to know, are the expected adverse effects proportional to the proposed use? We also want to know about subjects such as pregnancy and lactation. So how do we find that? Firstly, by doing non-clinical studies. So giving the medicine to animals and seeing what effects they get. And you can take higher doses and see what is the gap between the level at which you get no adverse effect and the level at which every animal gets an adverse effect. You can also look at pregnancy in animals. You can look at the effect on the fetus in animal models. And in those cases, we often use mice or rats or non-human primates. We then want to know in the clinical trials what the side effects look like. And Isabella covered the sorts of numbers. So the first in human studies are done in small numbers, one at a time. Give the medicine to the first human volunteer who's healthy, usually male, in 20s and 30s, and see what the immediate acute effects are. Repeat that in a second participant. And then in phase 2, we'll get some more data about safety, but also a little bit about efficacy. And in phase 3, the focus is really, does the thing work? But also, what are the side effects that we get? And you saw the columns in Isabella's slide. What is common? In other words, in more than 1 in 10 people, what happens in only perhaps 1 in 100, what happens in perhaps 1 in 1,000 people, and what are the really rare side effects that occur in even fewer people. But as she mentioned, we will only really know about all of the effects once we give this medicine to millions of people. So the second issue in safety is, how will further data on safety be gathered? So in this case with vaccines, they're called adverse events following immunization, or AEFIs. And we want to know, how will that be gathered? Will there be a targeted process to look for those side effects, what's called a risk management plan? And then we control access, looking at the safety and the efficacy to some extent, but largely the safety. Is this something which is prescription only, or is this something which can be sold in a pharmacy to be taken by a patient at home, or is this something which can only be used under professional advice. So as Isabella mentioned with these vaccines, we really want them to be administered in a place which is able to respond to those rare events, anaphylactic reactions, rare serious allergic reactions in people who get these vaccines. And we know that the number of cases is very, very small because we've now had millions dosed in the US in particular. Then we want to look at efficacy, the third element. Does the medicine achieve its proposed purpose in preventing or treating a disease or a symptom? And are there important differences in effect between patient groups, be that on age, on sex, on comorbidities, or taking other medicines? I just wanted to emphasize something about vaccine efficacy. Vaccine efficacy is a relative risk reduction measure. So we look at the risk in those who are unvaccinated minus the risk in those who are vaccinated. That should give us a positive answer, divided by the risk in those who are unvaccinated and multiply by 100. So it's not as simple as saying that 9 out of 10 people who are vaccinated will be protected. You're talking about the relative change in the risk of getting the disease between those who are vaccinated and those who are not vaccinated. So who makes that decision and who does the screening? A full dossier runs to hundreds and hundreds of pages. The Pfizer dossier downloaded is 1.98 gigabytes of data. It goes through an internal screening, so the staff first look at it and decide which of the committees or external evaluators will look at which parts of that. So some are looking at the quality, that's the pharmaceutical and analytical, and in this case, the biological committee. Some will be looking predominantly at safety and efficacy, that's the clinical committee, or in this case, the biological medicines committee again. Some will look at the scheduling, and the focus is there predominantly on the safety data as well. And then the pharmacovigilance committee might be looking at the risk management plan, the labeling, the professional information, what is often called the package insert, the patient information leaflet. Each one of those reviews is subject to a peer review. So a second evaluator or a second committee member will look at that review and make a recommendation. There is the possibility of the whole committee coming together to discuss the review, especially if there's a difference of opinion between evaluators or committee members. And then a recommendation is given to the authority, and the senior staff of the authority take that decision, and it is issued in the name of the CEO. Together with that decision come conditions of registration. So a certificate of registration is given, and then there are conditions. And in the case of the vaccines, many regulators are saying this is provisional registration for a year or 2 years, contingent on that applicant completing the phase 3 studies and doing the phase 4 post-marketing studies. In addition to the conditions, the regulator also specifies the wording of the professional information and the patient information leaflet. Importantly, the SAPRA decision has nothing to do with the price. It doesn't consider the price, and it cannot, by law, make a decision on the basis of price. The single exit price, if it's to be sold to the private sector, is set by the manufacturer or importer. There are important differences in the way that the Medicines Act works now, since it was brought into effect the last amendments in 2017. And in particular, Section 2B2B allows SAPRA to enter into agreements to cooperate with any other regulatory authority, but they can liaise with other regulatory authorities or institutions, and they can share information. And a reliance model means the individual data doesn't have to be looked at. Instead, SAPRA can look at some other regulator's assessment of the same data. They get it all, but they can look at that other assessment and then make a decision on the basis of that, relying on that other regulator's assessment. At the moment, SAPRA would accept a regulatory assessment from the major regulators, so the US FDA, the European Medicines Agency, the MHRA in the United Kingdom, Therapeutic Goods Administration in Australia, Health Canada, and Swissmedic. With biological medicines, there are two other aspects that need to be considered. The first is that every single batch normally gets tested prior to it being released, and tested by a laboratory which is contracted to do this by SAPRA. It's called the National Control Laboratory for Biological Products, and it's located in Bloemfontein at the University of the Free State. However, there is the possibility of reliance. So if the same batch has been tested by another control laboratory, and that same batch is sold in South Africa, and the conditions under which it was transported can be documented, there is the possibility of being able to rely on that other control laboratory. And then in the case of the adenovirus vectored vaccine, so that's the AstraZeneca Oxford vaccine, there is the possibility of, or the requirement rather, that this also have approval from someone called the Registrar of Genetically Modified Organisms. So within the Department of Agriculture, there is another approval mechanism, and that application is in place at the moment. So what about pricing? Although pricing is dealt with in the Medicines Act, it's not SAPRA's job at all. What the Act creates is a pricing committee, and it enables the minister to make regulations on a transparent pricing system. And in particular, it says that for any purchaser other than the state, the same price has to be paid by all of those private sector purchasers. And that is called the single exit price. There are exceptions to this, the Schedule 0 medicines that are sold in any retail outlet, and medical devices and in vitro diagnostics have been exempted a couple of times. Each of these is a time-limited 3-year exemption from pricing. But the only time that there can be an intervention of any sort is in the January of the year after the medicine is first put on the market. So every year in January, a single exit price adjustment maximum is set by the minister on the advice of the pricing committee. And that increase in the SEP is limited to a certain amount per annum. And every year that amount varies. And it's varied usually around about the inflation rate or less than that. So it has been 0 in 1 year, but normally increases around 2 to 4% have been pretty normal. In the policy, but not yet in law, there was a recommendation that we should compare our prices with the prices in other parts of the world and ensure that we get, if not the lowest price, close to the lowest price. It's been proposed but never implemented. In addition, the cost effectiveness of a vaccine might be looked at, or of any medicine, but at the moment those pharmacoeconomic evaluations are voluntary, and it's not clear what the implications are if a vaccine or a medicine is not considered to be cost effective. So I thought I would, before I finish, just talk a little bit about the prices that we've been offered and how they vary compared to other vaccines on the market. So if we take the $5.25 price that we think we will be paying for the AstraZeneca vaccine provided through the Serum Institute of India, that is around 78 Rand per dose. At the moment, vaccines are the second biggest cost driver after antiretrovirals in the state, in the public sector. And the prices of some of those vaccines, I think, would be quite surprising to people. So if we look at 3 of those vaccines, the pneumococcal vaccine, the hexavalent vaccine, which includes 6 different antigens in it, and the human papillomavirus vaccine, those vary from 300 to 380 Rand per dose. With the hexavalent, 4 doses are given in the first 18 months of life. 2 doses of the human papillomavirus are given in grade 4 to 9-year-olds. And for the pneumococcal vaccine, there are 3 doses given in the first 9 months of age. So you can see that for some of these vaccines, giving each child 4 doses of a vaccine which costs, say, 376 Rand in the case of the hexavalent vaccine, is a considerable investment. However, we only have about 1 million children born per year. So that means you would need 4 doses for 1 million people. So 4 million doses at around 376 Rand per dose. The challenge here is that we probably are looking at a far higher number of people, 25 million people who would need to be vaccinated within 12 months with a vaccine that's going to cost us somewhere from 70 to 300 Rand a dose. The difference between state tender price and private sector prices is quite large. The human papillomavirus vaccine, for example, is over 800 Rand a dose. And in the private sector, usually 3 doses are given of that vaccine. So we don't yet know what the arrangement will be for the pricing of this vaccine, whether the proposals that are being put on the table at the moment of, for example, those who are covered by their medical schemes paying double and therefore subsidizing at least one other patient would be put in place, and how that would be done in terms of the single exit price mechanism. So I wanted to direct everyone to a really good website. This is the International Coalition for Medicines Regulatory Authorities, recently put out a very good statement. This one is aimed at healthcare professionals, but it really goes through all of the steps of assessment of safety and efficacy for COVID-19 vaccines. It's a great resource for anyone who wants to have any questions answered on this. So I'm happy to stop sharing at this stage and see if there are any questions that have come from the chat, or if there's anything that people would like to raise with me. Thank you very much.
Thanks so much, Andy. There are a couple of questions that have come from the chat here and on YouTube. The one is just about, you talked about the reliance on other regulators for some of the decisions that SAHPRA makes, which in many ways makes sense. But of course, the risk is that if there's been political pressure put on other regulators, and we know, or we have suspicions about the political pressure put on regulators in the US, for example, under the Trump administration, is it wise for SAHPRA to be trusting their decisions on these things, or would it be better for SAHPRA to be making its own decisions and doing its own assessments?
So you'll notice that it's not just the decision itself that is relied on, but the report. And so those reports are extensive. And in particular, the European Medicines Agency creates what's called an EPAR, so a public assessment record. And that record is extensive. They run to 150 pages of detailed explanation of how they've pulled the data out of the full dossier and what the decisions are on that data. An assessor in this country can look at that report, and if there's anything which they want to get more information on, they can go back to the full dossier. But that report at least speeds up the process. So it's not just a matter of saying, they've said yes, therefore we'll say yes. It's about relying on a documented process. From the FDA, you'd want an unredacted evaluation report. And I see there was a question about the formula, and Isabella's put it up. So vaccine efficacy is the relative risk reduction between the attack rate in unvaccinated and the attack rate in vaccinated people, divided by the attack rate in the unvaccinated and then multiplied by 100. So that gives you the percentage. So it really depends on what that attack rate is. It's not just simply 95 means 95 out of 100 people.
Okay, thank you. The last question was then just about the single exit price and how that relates just to the private sector. And the indications that we have at the moment is that, who knows if this will change, but that there are, that the state intends to do all of the purchasing using some money from the private sector, but that there will just be one purchaser of all vaccines, and that it will then be distributed in the public and private sector, and there'll be some compensation from the private sector to government to pay for its members. So would the single exit, if that remains the plan, would the single exit price come into it at all, or would it just be one price for vaccines in South Africa and then for the rest to be sorted out between government and the private sector?
So my view is that it wouldn't apply at all. What I've seen in the media is often a misinterpretation. So, for example, there have been statements that the department could set the SEP at twice the acquisition price. And the point I wanted to get across there is that the department has no mechanism to set the SEP at all. The SEP is the choice of the manufacturer, but that is when it is marketing normally. Now, even if we were to have some sort of state tender price, and there's an exemption from tendering, there's a treasury exemption to say we're procuring differently because of this being a number of sources that we can go to. We can't put them one up against the other and get them to bid for a tender price. I think there should also be an exemption from the single exit price. Now, the question that should be raised is whether it's a good idea to allow the manufacturers to market this through the normal channels, or whether there should be some other mechanism to control access to it. And I think we should look back to the early stages of the pandemic, when we were heading into winter and there was a lot of pressure on the supply of influenza vaccine in this country. And there were allegations that some private sector purchasers seemed to get privileged access, others were unable to get it, or conversely, that the government was buying it all and no one else was getting it. And there was real concerns that some people who wanted flu vaccines just couldn't get hold of it, enough of it. So I think there is a good argument to be made for a more controlled system, but it has to be transparent. We have to know what volumes are bought, at what prices, and how the financing of that procurement will be done, mixing the fiscal contribution to a medical schemes contribution, or some sort of philanthropic contribution, or a contribution from companies, for example, wanting to cover their workers. But what's really important is that we know who's paying what volumes are being bought, and how they are being allocated to various parts of the community.
So again, the key question, the key issues of transparency and participation in this decision making, it applies to everything. Are there any further questions from anybody participating? Please just stick your hand up. There were a couple of questions in the chat that were for Isabella, and we'll go back to those afterwards. But are there any further for Andy? Please jump on in. Okay, I'm not seeing any questions.
Looks like everybody wants to hit Isabella. Sorry, I tried.
No,
but hey, law and regulatory is boring. Everybody wants to know about their allergies. Thanks, Sasha.
Thanks so much, Andy. And if we have any further questions, we'll definitely transmit. We'll send them through to you. Thank you. Isabella, there were just, I think, 3 questions, last questions for you. The one was from, I think, Spare, who said that they heard that the vaccine wasn't 100% effective, which is correct. It's not 100% effective. It is unlikely ever to be 100% effective, any vaccine. But the real question was, what would the impact be if somebody who has COVID at the time gets vaccinated? So if they are already infected with COVID and then they get vaccinated, what will the impact be on them?
Thanks a lot. I wanted to, the presentation of Andy was very nice and very, very interesting. Not boring at all for me, but yeah, my presentation was much longer. I think I killed everybody by the famous PowerPoint dead. No, yes. So to answer this question, indeed, it's not 100% effective, as also Andy said, is really relative to the attack rate, which is also depend indeed on the prevalence of the disease. So as I said, in the study, they were people indeed that also got infected in between so they got a test just after the first dose, and there is not impact in the sense that there is no any concern for the safety. And then indeed, the point is more than to understand how long you need to wait for the second dose. Because as I said, so if you have symptoms, acute symptom of a disease, you should not get vaccinated. As for any other vaccine, it's better to wait the acute phase of an acute infection to be vaccinated. But then if you just get the vaccine and you develop fever the day after, then is where it's challenging, because this fever may be linked to the vaccine or may be linked actually to your real SARS-CoV-2 infection. So the point is indeed to be able to, this should be seen case by case, in the sense is then if the symptoms persist, is not for sure the vaccine, because I've said the symptoms, the side effects, that adverse effect following immunization, and Andy said are usually they last 48 hours, 72, so very short. But if you have then a COVID infection, the fever will last longer, the symptoms as well, so you will get tested, etc. And I believe your second dose will be delayed, because then you will need to be again well before getting the second dose. So these are very, I think, decision that needs to be taken on case-by-case basis. But in the study, then there was not harm in vaccinated people with SARS-CoV-2 if you are not sick, so sick not to be able to get a vaccine, any vaccine. In the trial, people were healthy, so they didn't have symptoms at the moment when they got the vaccine. And yes, in terms of efficacy, you still need the second dose. The problem is to be able to respect the interval that has been recommended, because you know SARS-CoV-2 for some people may last weeks before to get recovered. So I think this will depend really on the decision of your doctor and the cost-benefit analysis.
Okay, so it's not dangerous to get the vaccine if you've got COVID. It's not recommended, but it's not dangerous. And the main issue is the gap between the first dose and the second dose, and whether you will be sick for too long to then get the second dose. But this is all questions that the doctor administering the vaccine will consider when they're doing so. I'm going to ask one more question before Moses's key HIV question. And that was just another question on the chat, which is about if you have allergies already, are you more likely to be allergic to the COVID vaccine or to have bad responses to the COVID vaccine?
There was in the slide, I think I put it because indeed, so the real contraindication is the fact of the allergy to one of the components, or indeed, if you got the first dose, you got a severe allergic reaction, you are not eligible anymore for the second dose. This is obvious. But then if you have also a precaution is the allergy to another vaccine or another product. So in your life, you got a vaccine before and you had a severe allergic reaction, that is a precaution. It means that the doctor needs really to think carefully about the cost-benefit analysis, and allergy to food, contact or seasonal allergy are not precautions at all or contraindications at all. There is not an increased risk. Is at the end, sorry, was in the contraindications and versus lack of data. So very mild allergy, so like indeed food or contact, etc., are not even a precaution. There is not risk at all. An allergy to any other vaccine or injectable indeed is a precaution. So the doctor should advise you if you get the vaccine depending on your specific anamnesis, so the story. What was the vaccine, what happened, what was the drug, etc. And but no, in the common allergy, no, there is not issue.
And can you quickly tell us, you have, I think, mentioned it, but if I get vaccinated whenever my time comes up, what are the very unworrying side effects I should expect? Although we're watching out for any side effects, but there's the swelling of the area, there's a bit of fever. That's the kind of thing that is normal for any vaccines, right?
Yeah, indeed. So I think the thing that myself, if I will get vaccinated, then I will get worried if any symptom I haven't experienced before. Or thinking about neurological symptoms, or also if I feel heavily weak, or things that are not common. Everybody of us got a cold once, so we know. But then if you experience something that is uncommon, and then also lasting, so it's not short, not really few hours or few days, then I think in that case I will ask my doctor if this may be related to the vaccine. And the issue is that then you need to establish a time relationship, because this can be like a coincidence or not. So, but anyway, it's very important to denounce, to record any possible side effect, and then there is an investigation to see if it was actually related to the vaccine or not.
Mm-hmm. And then just a follow-up to that is Julia's question, will healthcare professionals be given guidelines on administering the vaccines and assessing contraindications and any side effects?
So who will write these guidelines? As I said, for the Pfizer vaccine, the SAGE, that is the group of experts in immunization of WHO, wrote a specific guidance that for me is the reference I use for Pfizer vaccine, and they will do for any other vaccine that is going to be. As well, indeed, the regulatory bodies in the country, they will carefully also look at all the system to put in place to record side effects. This I'm sure will happen. And then I think also the health department will carefully also educate the doctors, inform the doctors about the management, etc. So guidelines will be available. For me, the reference is always WHO, because actually a national health body will refer to this anyway.
Okay, thank you. So then I think there we go. And Lydia says South African healthcare workers are already being registered for vaccinator training before being able to administer vaccines. So it's already happening. Now, the last question, which is of interest to many of the activists here, is about the HIV vaccine, and if this means that we're any closer to an HIV vaccine.
This is a very difficult question. This will be fantastic, honestly. We know I've been working in the HIV field for many years before joining vaccination. And the point, I think, indeed, what we have done for the COVID-19 vaccines changed completely the history of vaccines. And you can tell, because never happened something like this before. So there are a lot of lessons learned, which will help to speed up the process. Then I think that there are some requirements that we need to be met, like the public interest, the availability of a platform which can be indeed used. It also can, for which the process can be speed up. So there are different aspects about that. But for sure, today we have more hope that we had 10 months ago, if in my personal perspective. I don't know if Andrew wants to add something about that.
Yeah, I just wanted to make the point that actually a lot of the benefit has been in the reverse direction. So a lot of the work that was done on adenovirus vectored vaccines was originally done for HIV. And although those vaccines have not proven to be as effective as we wanted them to be, we learned a lot about how to pack genetic material into adenovirus and how to deliver those safely and what the safety issues are around viral vectored vaccines. HIV is very different. It mutates a lot more. It's the correlates of protection are not that well devised, but there is another aspect where there is an overlap. And that's the idea of broadly neutralizing antibodies and being able to convert those into monoclonal antibodies that could be used. So BNAbs that were, for example, found here in Durban in women who are persistently seronegative are being investigated to see if we can turn those into a medicine that we could use.
Thank you. All right, I think I'm going to call it here because I don't think we have any more questions and we are already 15 minutes past our intended closure time. But I wanted to thank both of our presenters so much for giving us so much time today and answering our many, many questions. And also to thank all of the participants for asking those questions, for sticking with us, and for being interested in vaccine literacy. We'll be sending out the presentations from both of the speakers to everybody who's participated and have been and registered. If you didn't register and you're using the YouTube link, please let us know and we'll send those to you. And we've been recording the session, so it'll also be available. So thank you very much to everybody for your participation and we hope you have a good day further. Bye.
Thanks a lot.
Thanks, Sasha. Thanks, Isabella.
Thanks, Andrew. Bye.
Ciao. Bye.
Bye.